I would like to welcome everyone today. This is Coffee with Dr. CJ, and I am Dr. Cathy J. Campbell. I'm a family medicine, sports medicine doc at Cleveland Clinic, Canada. Today, we're going to do an update on coronavirus and COVID. We're going to look at the virus, we're going to look at vaccines, we're going to look at some testing and a little bit on school and kids going back to school. In the past, this is our 14th webinar, and in the past we've looked at a number of different issues. We've looked at anxiety and stress and mental health issues related to COVID, related to going back to work, related to fear of financial problems, fear for our loved ones, and so forth. We've looked at cooking. We've looked at difficulties obtaining flour and yeast. We've looked at exercising with no facilities and many, many other issues. I also today wanted to thank Cleveland Clinic Canada and our CEO extraordinaire, Mike Kessel, for keeping us all working at this time. We have 2 clinics in Midtown and downtown Toronto, and we've all worked throughout this time, and we're very grateful to Cleveland Clinic Canada for that. I have 2 wonderful guests today. I'm very excited to introduce Dr. Rebick and also Dr. Matthew Cesari. Gabe, first I will introduce, and Gabe is an ID specialist, that's infectious disease, and he's also an internist practicing at Cleveland Clinic Canada, as well as Trillium Health Partners in Mississauga. He's returning to Canada after 6 years in New York City, so he's got great feedback and information for us on New York. And he's assistant professor of medicine at New York University in beautiful downtown Manhattan. He's a clinician, he's an educator, he is a clinical researcher, and he has obviously a great deal of experience with COVID-19, having worked through one of the heavier times of the pandemic in New York City. Dr. Matthew Cesari is board certified in anatomical pathology, specializing in gynecological anatomical pathology, and is also chief and medical director of lab medicine and genetics program at Trillium Health Partners. He's really an expert in all testing matters. So I know that a lot of you have had questions on testing, on the different swabs, on antibody testing, and so forth. So if you have questions for either of my guests today, make sure that you enter the chat box and send us your questions, and we will try to address as many as possible during this conversation. I would like to say that Dr. Cesari also has a master's in management from McGill University. So first, I'd like to welcome you both and thank you for coming on to the show today. And I'm going to put you on the spot immediately, starting with Gabe, and ask Gabe to give us at least one positive that's come out of COVID for you. I've been asking our different guests this question, and it's always interesting to look at something positive that's come out of something that's been so difficult for many of us. Either of a personal or professional nature. So I hand that over to you, Gabe.
Yeah, thanks, Cathy. Thanks for having me on the talk today. Excited to be here. Yeah, it's been a challenging time for all of us. In New York City, of course, we had a very challenging time throughout March and April. In terms of positive, you know, for an ID specialist, this is something we sort of read about and think about a lot at pandemics. And so, although being in the middle of one is not a lot of fun, from an expert standpoint, it's pretty incredible to try to tackle this, you know, really once in a lifetime infection. So at the moment it's tough, but I think in retrospect that will be a positive, just having been part of the group that, you know, managed this incredible disease. Another personal positive nature is COVID brought me together with the Cleveland Clinic. So part of the reason I'm involved with Cleveland Clinic Canada is to offer some infectious disease expertise on COVID-19. So that's been an exciting relationship, and I'm happy to be here.
And we're excited to have you. So thank you. Matthew, how about you?
Well, first, thank you very much for having me today. It's absolutely wonderful opportunity. I'm so pleased to be able to have a discussion with both you and Gabe today. There's been so many positive things actually coming out of COVID, despite the fact that it's been a global disruptor. From a healthcare perspective, I think it has brought an opportunity to move certain projects ahead that have been sort of staggering and lingering. And I'm just going to use the example of virtual care. And I think in Ontario, we have taken virtual care to a whole new level, and we've run with it. And I think it's an absolute positive thing that has come out of COVID. And it's something that we have to seriously consider, think about, and identify what are the positive aspects that we're going to keep out of this moving forward. On a personal note, I think COVID-19, just like Gabe, has brought me to the Cleveland Clinic as well. So that's the new relationship that we're exploring. The other aspect, personally, I think it has been a really great time to sit down and reflect and think about what it means to cope, what it means to adapt, and to take a look at my personal capacity to do so. And so really trying to apply things like mindfulness, for instance, and self-reflection. I think it's a great opportunity. It's perhaps a once-in-a-lifetime opportunity as well, hopefully a once-in-a-lifetime opportunity to do this, but you know, trying to seize the moments in the worst of times.
And that's really interesting, because probably one of the biggest topics that we've covered during this time has been around mental health, around mindfulness. We've done several sessions on mindfulness, anxiety, stress, and so forth. And it has been a time of reflection. It's been a time for us to really step up as well, an opportunity to show our best selves and to step forward and so forth. It certainly has been a difficult time for many. So thank you to both of you. And again, I really appreciate you being on the show today. We've got a lot of stuff to cover. I'm throwing a lot of things at you today. So we're going to start right off with this beautiful picture. And it always reminds me of our respirologist on the team, Dr. Khalil Sivji. He talks about this often, and he calls it the ballistics of respiratory droplets. And basically, this is our original thinking and belief how COVID spreads through the spitters that spit when they talk, or through people coughing and so forth. Generally, these droplets that carry the virus can go out about 2 meters or 6 feet. There's been more information lately about aerosols. Maybe it can be spread other ways. And perhaps Gabe, being an infectious disease expert, you could comment on this. And does this picture still reflect the best impression of how we spread the virus?
Yeah, thanks for the question. So when we think about droplet transmission of infections, COVID is certainly in our minds. Influenza is another one that's we have to deal with every year. And so what does that mean? It means that small water droplets from our mouth when we either cough or speak, sing, are sort of dispersed out into the air. And these are droplets of different sizes. So they're certainly not all the same size. They really range from somewhat large to somewhat small. And so the way that the picture shows here is that the droplets will gravity will bring them to the ground. So if you're far enough away from somebody, gravity should have brought most of the droplets to the ground by the time you get there. I think so the social distancing point is that, you know, we believe that most of the infections are transmitted by so-called large droplets. And so if you're 2 meters away from somebody, those large droplets should have adhered to gravity and got to the ground before they reach you 2 meters away. there's been some controversy, as you mentioned, about so-called aerosols. So what is an aerosol? So we think about aerosols as things, droplets. Well, classically, aerosols are droplets that evaporate. And so they become these very small particles that are then able to rest in the air and be in the room that you're in. So some of the diseases we think about being transmitted by aerosols are things like tuberculosis, measles, or chickenpox are the classic examples. And so one example of an aerosol transmission might be chickenpox. They've seen cases where in a pediatric waiting room, for example, if a child was there with chickenpox, an hour later, another child could come into that waiting room and become infected. So when we think about aerosols, we think about these very tiny particles that are able to sort of be in the air, and they don't actually fall to the ground. Sometimes air currents can bring them up, and so they may remain in the air for an indeterminate amount of time. And so some of the controversy has been about this concept of, well, how long does the droplet stay up in the air, and also how far can it travel? So we've seen some community transmission where there was concern that there was more of an airborne transmission, meaning people were more than 2 meters away, but they still were able to become infected. So one of the examples that is often cited is a choir practice in Washington State of the United States, where there was a huge outbreak where a vast majority of a choir all got COVID, and they were all practicing careful social distancing. So this raised the alarm about airborne transmission because they weren't within 2 meters. And so some of the thinking about that is probably there are some very small droplets, usually cited as less than 5 microns, where they may travel further than 2 meters. And so I think some of the concern from scientists, there was a recent editorial that was published, may be that these may potentially play a role in transmission in certain settings. And the setting we're most worried about is an indoor setting where there's poor ventilation. So this could be a situation where maybe the church had very poor ventilation so that these very small droplets are being dispersed, but they weren't going anywhere. They were just sort of staying in the room where the people were having choir practice. And because of that, they were enabling infection. So one of the reasons why we're recommending people be outdoors is that obviously outdoors is a perfect sort of ventilation situation. So these droplets really would be dispersed by crosswinds, et cetera, and really not pose a risk. In terms of whether we think that airborne plays a major role in infection, overall we don't. And some of the reasons for that is that, in general, the practices we've been doing to prevent droplet transmission, as evidenced by this graph, and social distancing have been working. And so there's a lot of examples of, infection control practices targeting droplet transmission working extremely well. And so for that reason, we really believe that the vast majority of transmission is happening from these large droplets. And although the small droplets, or so-called aerosols, may be a cause for transmission in some rare situations, we don't believe it's the major reason for transmission.
So face mask check for people with symptoms and without symptoms. As we now know, asymptomatic spread or pre-symptomatic spread is cause, and still keeping certainly the 6-foot distance is certainly still important.
Exactly. Just to reiterate that point about face masks, we think about the primary purpose of face masks is to prevent the dispersion of these droplets. So they work quite well at preventing those droplets from being spread. So if you happen to have infection and not know it, then you won't be a source of infection to those around you if you're wearing a face mask.
Yeah, thank you. So there's all kinds of testing, and we're all confused. We know the nasopharyngeal swab, that horrible one that goes to the very back of the nose that no one likes. But there's new testing, and actually, interestingly, I saw this morning that the FDA in the US just granted emergency approval for the rapid COVID-19 saliva test. And that was just this morning. So I'm going to hand this slide over to you, Matthew. I know this is your expertise, and maybe you could fill us in on when we should do what and the usefulness, for instance, of antibody testing.
Absolutely. Pleasure to speak on this. And I think you're absolutely right. No one who has had a nasopharyngeal swab will ever forget having had a nasopharyngeal swab. It's a very memorable event. And if you've had two, for sure you'll remember it. This slide is really well set up because I think it really targets two different types of testing. And it's often useful to think about testing, especially with this virus, in terms of acute phase testing and convalescent phase testing. So basically people early on in a disease course where everything to the left would be probably more useful to them. And then convalescent, or when you're sort of in the healing phase and recovery phase of the disease, then we're talking about tests on the right of this swab, of this slide. You know, I see the world in terms of swabs these days. The testing in the acute phase basically focuses around nucleic acid identification, and specifically the nucleic acids of the virus. There's also another type of acute phase testing, which is called antigen testing, which is looking for specific proteins that are produced by the virus itself. In general, and you know, without reviewing specific data on specific types of modality, but in general, the performance characteristics of antigen tests are not as robust as those of nucleic acid tests. Now, nucleic acid tests have to be collected, and so the sample has to be collected, and what you're depicting here on the slide are different ways that we can actually collect a specimen to look for viral nucleic acids. So nasopharyngeal swabs, everyone I think is familiar with it. Mid-turbinate swabs is basically a nasopharyngeal swab that isn't taken as far back in the nose and throat. And then there's the possibility of collecting virus through saliva. The advantage to the nasopharyngeal swab and mid-turbinate swabs is that they tend to yield better results on the test. And the test itself looks for genetic information and specific genetic information that we find in the virus. So we run it on a platform that's called reverse transcriptase polymerase chain reaction, so RT-PCR. And what this boils down to is once you've taken the sample, once you've taken the swab, we're going to spin the swab in a collection media to make sure that the virus falls off the swab and goes into the collection media. We then treat that collection media in a series of chemical reactions to basically leach out the nucleic acids of the virus. And while we're leaching out the nucleic acids of the virus, unfortunately, we're also leaching out the nucleic acids of the cells from yourself that have been picked up by these swabs. So what we have to do then is run a process that will identify the nucleic acids of the virus and distinguish them from the nucleic acids of the human. And we use RT-PCR to do that. And so we design specific probes to genetic information that are specific to the virus type of nucleic acids. We amplify those, so we basically replicate them. And then our probes have a light molecule on them, a molecule that emits a light signal. And so by looking at how quickly the light signal develops over time, we can actually be confident that viral DNA is, viral genetic information is present or absent from a sample. And we basically distinguish it that way from human genetic material. The technology in any type of test is the technology that sort of defines your collection medium. And so while we can, in theory, look for genetic information in multiple different types of samples, the utility of the test is really how well you will pick up the genetic information and how specific it is for exactly what you're looking for. And so when it comes to that, in general, the nasopharyngeal swabs and the mid-turbinate swabs tend to yield a better result on an RT-PCR platform. That's not to say that there's no value to any other collection modality like saliva. And when you actually look at the literature on saliva collection, certainly you can pick up genetic information. The question is it as robust as nasopharyngeal swabs or mid-turbinate swabs? And it may or may not be the case depending on your platform and how you have set up your testing modality.
So Matthew, this emergency approval through the US of the saliva, so they'll have results quicker, I assume, but probably a higher false negative, perhaps, is what you're.
So it's possible. So I haven't seen the performance characteristics of that particular assay, and I'm not sure whether or not that particular test is a nucleic acid or an antigen-based modality. In general, at least when we've experimented with saliva, you definitely can pick up virus. That is without a doubt. The question is, how well do you do it? And there seems to be, at least to my knowledge, variation, specifically with how far away you are from sort of full incubation and onset of symptoms. So when someone is really shedding virus, it seems to work pretty much equivalently to the nasopharyngeal swabs. But then there seems to be this dilution effect as the viral loads and the viral shedding goes down, that the amount of saliva that you collect sort of dilutes it out and makes it harder to pick up.
So for the audience, so early on in the infection when there's few symptoms, or more in the recovery phase, would be harder with the saliva from your experience at this point.
Correct.
Yeah.
That's been our experience. You know, whether or not this new modality actually has some better performance characteristics, certainly I'll be taking a look at that. I think it's a really interesting way to go because it facilitates the collection, makes it much more pleasant for people to actually have the collection. The speed of the results depends on a couple things. It depends on the technology itself and the modality of testing that you're going through. So if you have multiple reactions that you have to run a sample through, that takes a lot longer to actually get a result. And so it depends on what the specific test requires. There are some options on the market, and these change from jurisdiction to jurisdiction, but there are some options where you can take a nasopharyngeal swab, for instance, plop it directly into a machine, and within about an hour, you have a result. Those, so far, the majority have had a varying performance characteristics that have not necessarily been up to par to what certain health jurisdictions have been looking for. But certainly the closer you get a test to whoever is taking the test, the faster you'll get a result. And that's the entire concept around point of care testing.
All right. Did you have anything else you wanted to say about the antibody test, or?
Absolutely. I think antibody testing is is taking off. It's a very interesting subject. Antibodies are basically the proteins that protect us against infection, and certainly Gabe, I'm sure, can clarify any misconceptions that I may have around this. But these proteins are immunoglobulins, and they sort of bind to pathogens, and they protect us from the disease. There is, I think, ample evidence that we produce antibodies to SARS-CoV-2. The length of our antibody response is still perhaps being debated, and the robustness of the immunity that we develop is also part of that equation. But we do have technology on the market that allows us to identify these antibodies in an individual. So when they're present, in general, this would signify that you're on the recovery side of an infection. And so it can be useful in certain contexts. And so if we look at the Ontario jurisdiction, for instance, antibody tests has just been released by Public Health, specifically for a couple of scenarios. The first is For children that have a multi-system inflammatory syndrome where the diagnosis of COVID is actually uncertain, if you can demonstrate the presence of antibodies, that would really push you to accept the entire syndrome as being COVID related. In other scenarios, antibodies can be useful. Again, looking at the concept of whether or not you need to know if this is COVID, and if you don't quite have an answer through the PCR tests, the presence of the antibodies can help guide you and make that decision as to whether or not someone actually has been suffering from COVID. And so the blood draw tends to yield the more robust answer to that. There are some point of care antibody tests on the market, and in my experience and what I've seen, the performance characteristics really don't compare favorably to the blood draw.
Right. Thanks very much. We're going to talk very briefly. I know time is ticking by here, but I just wanted to mention that I know Gabe has two girls, two children, 4 years old and 1.5 years old. And certainly the pediatric societies in the US and Canada have suggested that school is a good thing. It teaches social skills. Kids want to have other kids to play with and learn with and so forth. Can you briefly, as a parent, before you send your kids to daycare or what have you, are there some specific criteria that you are looking at before letting your kids go back into a daycare type setting?
Yeah, so it's obviously a topic at the front of all of our minds about reopening schools. We certainly want our children to be in school. They want to be there, most of them, and so it's a tough decision. You know, I think that the most important thing to look at is how much disease there is in your community, and so you know, as much data as you can find to investigate that with your provincial public health resources, your local public health resources, even down to the neighborhood level, you can have an understanding of how much disease there is. You know, different governments are using different sort of criteria to establish what they believe is a safe number to send kids back to school. I don't think that any of those criteria have a huge amount of evidence behind them. Obviously, we want as little as possible in terms of transmission, because what you're looking at is, what is the chance that when your child is going to school, there's going to be another child or a teacher or someone who works in the school that's going to have the infection? And then given that knowledge, obviously all the other things come into play about prevention of infection within the school. So should there be somebody there with an infection, what's the chance your child is going to get that infection? What's the chance there's going to be an outbreak in your child's classroom, et cetera? So, you know, by far and away, the most important thing is the amount of disease in the community. And so when I think about sending my daughter to school, that's really what I'm looking at is, you know, does your local health authority have COVID generally under control? And you can debate as to what the best numbers are for that. And your own personal risk tolerance might point you in one direction or another, but I think that's the most important thing. And then secondarily, infection control measures within the school are clearly very important. You know, it's a long discussion about class sizes and social distancing, but doing our best to reduce the risk, should there be a case in the school that's transmitted amongst other children.
I'm going to keep you guys moving here. So here's a picture of busy New York City. And although time is limited, I know, Gabe, we've got to have a couple of words from you about your experience in New York City. I'm sure it was unbelievable with everything that went on. But I'm going to direct you to give us maybe 2 top things that you would, when you looked at that experience, that you could offer in terms of, let's say, containing the virus. What are perhaps 2 top things that the New York, United States and Canada should be doing to contain the virus?
Yeah, so as you all probably know, New York had one of the worst outbreaks in the world, if not the worst outbreak. Estimated based on serology tests, in the range of 15 to 20% of New Yorkers had the infection. So we're talking about somewhere in the range of 1.5 to 2 million cases of COVID, and we had at least recorded about 32,000 deaths. So pretty terrible. You know, I think that the big takeaways, why was it so bad in New York? Number one was a lack of testing and poor testing turnaround. So in early March, we clearly had a lot of COVID going around. There was there's a lot of restrictions on testing. So we didn't have a good idea of how much disease was in our community. And so I think that's not an issue in Canada anyway. Still an issue in some parts of the world, but so knowledge about how much disease on a day-to-day basis is clearly very important. Infection all these things we learned about in terms of how to stop the spread of the disease, we just weren't practicing in New York in early March. So people were still going to work, schools were still open, restaurants and bars were still open. No one was wearing masks. At that time, there was not a lot of knowledge about pre-symptomatic or asymptomatic transmission. So at that time, there was concerns about PPE shortages, so it was recommended not to wear masks. And so a lot has changed. I hope that there'll be an outbreak of that proportion will never happen again, because we know a lot more about how to control the virus. And I think, the lessons learned are those things I mentioned. Make sure you have adequate testing in your community so you know how much disease there is. You can do contact tracing. A robust public health authority and resources to those units, including contact tracers, testing, et cetera, is critical to be sure that there's not sort of an outbreak that's under the surface that we don't know about. If we have data from our public health authority, we can see when that little uptick goes from 100 cases to 200 to 500 to 1,000. We know there's a problem. If we had that in New York, it would have been 50,000, and hopefully we would have never got there had there been that in place already.
Mm-hmm. And perhaps Matthew, you could briefly explain how do they set up this vaccine trial, and why these phases? What are these phases, and where are we?
Yeah, I think that's a really great question, and certainly when it comes to vaccines and drugs, it's there's a really well prescribed way of getting something from the laboratory to people in a very safe way. And so you can look at phases of clinical trials. There's phase 1, 2, 3, and 4, and there are two big broad buckets. This is how I conceptualize it. There are two big broad buckets of information that we're trying to collect. The first is about safety, and we're looking both at short-term safety, medium-term safety, and long-term safety. And so we collect that data throughout all the phases. So phase 1, phase 2, phase 3, we release, and then we do a post-release phase 4 clinical trial. And the phases sort of get longer and longer as you go through the process. The other bucket of information that we're trying to look at is in phase 1, we're trying to look at dosing and how to deliver this to individuals. Phase 2 generally focuses around the efficacy of whatever it is you're trying to bring to market. That's taken to a longer step in phase 3, and then post-release, a phase 4 trial, you're really looking at long-term safety. So you're kind of looking at a couple months, phase 1, to extending it to around 6 months for phase 2, and then 6 months and a bit more for phase 3, and then a year or more for phase 4. In general, of course, all these timelines are variable on what you're trying to capture in terms of data. What we've seen is some really interesting ways of trying to reduce these timelines by trying some individuals have been sort of overlapping some of these trials, which has been a really interesting way of trying to shorten these timelines. Personally, I kind of get nervous when we start talking about accelerating things through clinical trial phases, mostly from the safety perspective, because we do want to make sure that we keep line of sight on long-term potential consequences of either a vaccine or a drug. That being said, we have to temper that with what the overall need is in the population. That's kind of the way I conceptualize the phases of clinical trials.
What would you say, Gabe, is the top trial or trials right now, and where are those located? Even if we do find an efficacious vaccine, one that is working, how likely is it to get to you and I in a timely manner in the next year even?
Yeah, I mean, that's a great question. So there's a number of vaccines in phase 3 trials. So phase 3, as Matthew said, is the larger trial looking at efficacy. So The way that phase 3, in this scenario, you would vaccinate large numbers of people in the thousands and then monitor them over time to see if there was a difference in the number of people who got COVID in the vaccine group versus the placebo group. And so you can see why it would take a lot of time to complete these trials. You have to enroll thousands of people, vaccinate them. In this case, it's often 2 vaccines over a period of, say, 4 weeks or so, and then watch them over time to see if they get COVID and if it's efficacious. And so it's going to take some time. So there's 8 vaccines in phase 3 right now. All of these have shown robust antibody production in the phase 2 studies. So evidence that it elicits an immune response from the humans. We don't know at this point what that means in terms of prevention of COVID. So it's very important that we complete these phase 3 trials to know, number one, if the vaccines are efficacious. Number two, if there's any safety issues that weren't seen in these sort of smaller trials. And there's always a chance that a vaccine could be harmful. There's a lot we don't know about COVID. Clearly there's an immune response which malfunctions in the humans that leads to some of the death. And so one of the concerns obviously would be that it could be that a vaccine might make that worse. We really don't know. And so when we talk about why is it not a good idea to give a Russian vaccine with no testing, for one thing, it could be harmful. It could not work. And I think a major concern for a lot of healthcare providers is that vaccine uptake is going to be critical in terms of how efficacious vaccines are in the community. So are people going to get the vaccine? And so if we roll out a vaccine without enough information and we start to see sort of rare or serious side effects, that might impact the number of people who are willing to get a new vaccine, whether or not it's, the better tested ones are safe or not. It may just color people's opinions of the COVID vaccine, whether or not it and may impact the amount of people that get vaccinated. Because clearly, putting an end to the pandemic in regions will hopefully we'll have an effective vaccine. We can't promise that, but it'll also matter what percentage of the population gets that vaccination.
Mm-hmm. So we have a bunch of questions, and we have about 6 minutes, it looks like, and we're going to start with my question. So I have a question, and I've been thinking about this. Sometimes I think, and I've been thinking about this one. And so coronavirus. So people know out there, there's many coronaviruses. And what is a coronavirus? It really is, it describes the presentation of the virus. Corona means crown, and we talked about this in an earlier webinar. So if you kind of squint and look at this picture of coronavirus, you can see it almost looks like a crown. These little virus particles or these protein bits sticking out kind of look like a crown. And so there's many different kinds of coronavirus, and the 3 types that we know most about and that were most severe were MERS, SARS, and then finally the COVID-19. And COVID-19 really stands for Coronavirus 2019. So if they all have a similar appearance with these proteins and so forth, one thing that I'm curious about is we almost for sure we'll have another coronavirus. So it'll be another coronavirus. And rather than start at the very beginning trying to develop a vaccine, and I stole some of these ideas from CBC recently, rather than starting at the beginning with a new vaccine for coronavirus, just one thought I had is, why can we not do sort of a basic platform based on the ones that we have had and then tweak it for the next one? Because it takes so long for these vaccines to be produced. And we talked briefly about this before, Gabe, and you had some thoughts on this crazy idea of mine.
Yeah, so yeah, coronavirus, before the viruses listed here are the serious ones that have emerged in the last 20 years or so. But before that, really, coronaviruses were cold viruses. They were generally quite mild, and we all kind of got them from time to time. Thought to make up about 5 to 10% of the cold viruses circulating, along with some other viruses. So this particular virus is certainly unique, and there's definitely a possibility that another coronavirus could emerge in the future. Vaccine development is really very specific for the infection itself, but it's possible that one of these vaccines might provide some protection against a future coronavirus. I guess we really don't know. There's some data coming out that having had other types of coronaviruses may provide some mild protection against this coronavirus. So I would say that, they're not exactly the same, but, in terms of future pandemic planning, we have an enormous wealth of information as to how to avoid this scenario in the future. And obviously, if we were to emerge with another pandemic, clearly a lot of information about how to develop a vaccine quickly. So hopefully we'll be more prepared for the next pandemic.
Hopefully. Another question. Sorry.
Can I add something? I think there's some really interesting data that's coming out of the study of COVID in particular. And I think there's a lot of new and novel genetic information that we're capturing with genome sequencing of data, especially with the technologies that are available to us these days for research. And there, it may just be that moving forward, we may move away from vaccines, and there may be other alternate technologies that come out that will actually help us fight pandemics like this. So, I'm just throwing out the idea perhaps of laboratory generated antibodies that can actually help to prevent sequelae of pathogens that you would contract. And I think the more we study the pathogens, the more we understand how the genetics come to play in this, we may actually find some novel therapeutics on this that we would be able to bring to market a lot faster.
So another question here, has there been any indication that immunity would be permanent through recovery or through a vaccine?
So I'll try to answer that one. I guess the short answer is no. There's no indication that immunity will be permanent. We just really don't have enough information right now on immunity in general. One of the concerns is that other coronavirus infections, you can potentially get them a second time, like cold viruses, for example. So one of the concerns is that it may be possible to acquire COVID again. Obviously, the hope is that if this continues to circulate, a second time would be not as severe and potentially not life-threatening. In terms of whether actual infection or vaccination will have true permanent immunity, I would say we really don't know. That would be a best case scenario, but we have to plan for all scenario.
Now I have one quick last question. What kind of tests are recommended for small kids if they have flu-like symptoms?
That's a challenging one because kids often have flu-like symptoms. Certainly, if you're considering COVID, or if your healthcare provider is considering COVID as a diagnosis, the testing modalities are basically the same, whether you're adult or not. Depending on the age and the size of the child, the type of swab may be different, and maybe we would move from a nasopharyngeal swab to another form of collection, perhaps a throat swab, if that would be easier to collect. But in terms of the technology and the assay itself, they're basically the same.
I'm going to add one quick last one here. There's quite a few questions that have come in, but one is about in Canada. We know that they've just approved the saliva test in the US, but in Canada, there hasn't been approval of that. Or the question was around, is there any chance in Canada for availability of home testing or testing in office situations for either antibody or the saliva or point of care type testing?
That's a really great question. I think certainly the field is trying to move more and more towards point of care testing to make testing more readily accessible.
Can you just quickly explain point of care for the audience, what that implies? Yeah.
Point of care is bringing the testing directly to the point of collection. So if I'm being tested and I get a swab, the swab would go straight into a machine and out comes a result. So,
like an instant strep test or something like that. Yeah.
Exactly. Yeah. So Health Canada has been very diligent and doing very good work in making sure that the technology that is being brought forth is reliable and safe to use. And I think we've got whether or not we bring in a point of care test really has to take into account the environment and how it's going to be used and the information that it's going to generate. And so far, in general, the performance characteristics haven't been the best for the point of care testing to make it more readily available. That being said, I don't think the position is that there's no utility to it. And I think you also have to look at it in context. When you have a really, really high prevalence in a population where the disease is uncontrolled and you just need to get some information in order to be able to action, there is a lot of utility to bringing in tests that don't have the best performance characteristics. And so the question becomes is what is the utility of it in the population that you're trying to work with, and what are you going to do with the information? And certainly I think what we do know and what we have to be careful of is to not get a false sense of security from a negative result, whether or not you're using point of care or non-point of care testing. And I think that's a lot of the considerations that have to go into whether or not we bring testing directly into the workplace or at home.
Mm-hmm.